Hello, welcome to Holmes Community College Paramedic Program. Glad you're here. Tonight's lecture is Arrhythmia Classifications, the Sinus Rhythms. We address and identify arrhythmias based on their location of the pacemaker, and the sinus rhythms are the rhythms that are generated with their first electrical impulse originating in the SA node, the sinoatrial node. Yeah, that gives them some very distinct characteristics that are unmistakable. If they start in the SA node, if they are sinus rhythms, all of the P waves should be alike. If they're sinus rhythms from the sinoatrial node, all the P waves should look alike. The questions that we'll ask about each one are the questions that we talked about in an earlier lecture, which is rate, regularity, and that says regularity. The P wave questions: are they round? Are they upright? Are they all alike? Is there one-to-one with the QRSs? PR interval, is it within normal limits, which is 0.12 to 0.20? And then the QRS, is it within normal limits? 0.04 to 0.12. So for the sinus rhythms, again, they start in the SA node. This is the electrical impulse that begins the cascade of electrical stimuli to the interatrial pathways that cause the depolarization of all the atrial cells simultaneously to generate that atrial kick. The SA node has an intrinsic firing rate of 60 to 100. When we look at rate and we're determining the rhythm, we'll keep in mind that if it's outside of 60 to 100, that there is that it is an arrhythmia. So before to start the sinus rhythms, how about we name all of them first? Normal sinus rhythm, sinus Brady, sinus tach. There is a sinus arrhythmia. That's its name. It spells arrhythmia, I'm sure. There's a sick sinus syndrome. There's a sinus block. There's a sinus pause. There's a sinus arrest. There's a lot, right? Not really. But that is all of the sinus rhythms. There are no more. One thing we know about all of these rhythms, that atrial depolarization that is shown on the EKG tracing in the form of a P wave, because the atria up here contracted in synctum and generated that positive deflection in the beginning of the EKG tracing. All these P waves are going to look alike. So how do you determine which rhythm I'm looking at when I look at the EKG monitor? Lead 2, I'm looking at lead 2 because generally speaking on a normal heart we're going to see the greatest positive deflections as we move the electrical energy SA node toward that positive limb lead left leg, because as we're moving from the right atrium, SA node, AV node, bone heads, we're moving toward that positive electrode on that left leg. Normal sinus rhythm, what's the rate? 60 to 100, because that is the intrinsic firing rate of the SA node. 60 to 100. Is it regular? Yes. Are the P waves round and upright? Yes. Are they all alike? Yes. Is there one-to-one on the QRSs? Yes. So they're round, they're upright, they're all alike, and there's one-to-one on the QRS. The PR interval, the amount of time it takes from the beginning of the P wave to the beginning of the QRS is within normal limits. 0.12 to 0.20, that's a yes. QRS within normal limits, yes. All of these have to be answered for it to fall inside the category of normal sinus rhythm. Anything that's not in this set of rules excludes it from normal sinus rhythm. So what do we do to fix a normal sinus rhythm? Nothing. What if they've got a bad map? What if they've got an altered mental status? What if their blood pressure's low? What if there's some problem with the patient that needs to be corrected? It's not the rhythm. We can get involved in correcting a map without correcting the rhythm. We can increase preload, the amount of blood returning to the right side of the heart and the left side of the heart before systolic contraction, putting volume in. We can increase the strength of contraction, change the amount of stroke volume by using drugs that make that left ventricle contract harder, inotropes. Or we can, on that systemic vascular resistance side, all the way on the outside of the heart, cardiac output times systemic vascular resistance equals blood pressure. We can correct the size of the pipes. So we can still increase a map on patients that need help, that cardiac output demands aren't meeting the metabolic demands of the brain, but we don't do it by correcting the arrhythmia. So, normal sinus rhythm. How do you know that? Those answers, you memorize them. Sinus Brady, rate, less than 60. Is it regular? Yes. The P waves, round, upright, all alike, 1-to-1 on the to the QRS. Yes. Is the PR interval within normal limits? 0.4 to 0.20. Is the QRS within normal limits? Yes. Alright, so now we've got a heart rate less than 60. This is an arrhythmia that can cause decline in the ability of the human to meet metabolic demands of the brain. We may correct this arrhythmia as part of the way we correct the mean arterial pressure, is the way we actually correct what's going on with the human's altered mental status, or that, like I said, that mean arterial pressure that didn't get to that 65 or greater. I'm going to do the treatments a little later. Sinus tach, the rate's greater than 100, less than or equal to 150. Is it regular? Yes. We're really not changing much on these, are we? The only thing we've changed is rate. Are the P waves round, upright, all alike, 1-to-1 on the QRSs? They are. PR interval within normal limits? Yes. QRS within normal limits? 104.12? Yes. So on sinus tach, that's where we're at right now, sinus tach, you've got a rate greater than 100, less than or equal to 150. That rate is a likely compensatory, is probably correcting some problem the human was having, either with stroke volume being inadequate, or the pipes being too big. Sometimes the heart rate on the autonomic side, the parasympathetic side, will increase rate based on fear, or based on the anticipated need for the increased cardiac output to outrun a bear, or a bad guy. So I'm not running from bad guys. Anyway, that's another thing. So sinus tach, we don't correct this. If you've got someone that's got a heart rate of 140 and you start tinkering with the rate without fixing the problem, we may have someone now that can't meet the metabolic demands of the brain. Don't mess with this rate. Find out what the problem is. Are they in pain? Are they anxious? Are they compensating for some kind of shock? We need to fix the underlying problem, not the arrhythmia. And it is an arrhythmia. The only ones that aren't arrhythmias are the ones that fall in that normal sinus rhythm category. So, sinus tach. Sinus arrhythmia. What's the rate? 60 to 100. Is it regular? Yeah. Yeah. Yes, it's regular. If you look at it, you're going to see some slight variations from R wave to R wave. Slight variations. You can see them, but they're not gross. The rate should not be changing from 60 to 90. If we're looking at the monitor, you may see a rate that's in the 70s, 71, 72, but then the monitor's toggling back to 69 to 73. There's not giant changes from R wave to R wave, but they are not absolutely regular. If they were absolutely regular, and all these others are answered with yeses, it would be a normal sinus rhythm. It's not a normal sinus rhythm because right here it is slightly irregular. And if you glance at it, you may not even see the irregularity is so slight, sometimes associated with just the inhalation, exhalation, the ventilatory exchange. So sinus arrhythmia, what do we have to do to fix it? Absolutely nothing. We don't fix sinus arrhythmia. We don't fix sinus tach. We might fix sinus brady, and we don't fix normal sinus rhythm. These are rhythms that if the patient has a decreased mean arterial pressure, it's not the rhythm's fault, it's something else. We're either not getting enough blood in there during diastole, passive filling, or we don't have a strong enough contraction to create the adequate stroke volume, or we don't have small enough pipes on that systemic vascular resistance when we multiply cardiac output times SVR to get to the blood pressure. So sinus arrhythmia, again, is not a correctable arrhythmia. And I don't think you're going to see in the American Heart Association guidelines associated with sinus arrhythmia. When they said, is it regular, you would say, no, it's not regular. All right, sick sinus syndrome is weird. You don't see it a lot, but what you do see is a sick SA node that will have a rate that moves between normal cardia, which is 60 to 100, tachycardia, or bradycardia. So we're going to have a rate that can be less than 60, greater than 100, or 60 to 100. We're going to see some periods of normal cardia. I may see several QRS complexes in a row, and I calculate the rate of 80 or 90. It might look like a normal sinus rhythm, but that sick SA node will quit firing at that rate of 60 to 100 and drop into a bradycardic range below 60. Or it may go above the tachycardic range, which is greater than 100 but less than or equal to 150. So a sick sinus syndrome is going to be irregular in that it moves from normal cardia, bradycardia, tachycardia. And it doesn't have to move in those, in the order that I just spoke. We may see bradycardia to tachycardia to normal cardia, or vice versa. You could see changes where we move from brady to normal, and then back to brady, and then to tachycardia. It's a sick sinus syndrome because the SA node is failing to maintain a normal patterned rate. Are the P waves all alike? Yes. Are they rounding up right? Yes. Are they present, round up right, all alike, and 1-to-1 on the QRSs? Yes. If they're not all alike, it's not sick sinus syndrome because some of those complexes are being generated somewhere besides the SA node. When it's a sinus rhythm, all of these rhythms have one thing in common, definitely, and that is that the P waves are all alike. The PR interval within normal limits. On those bradycardic periods, they are within normal limits. On those tachycardic periods, the PR interval is 0.20 to 0.20, and on those normal cardiac periods, the PR interval is 0.20 to 0.20, and the QRS within normal limits. Sick sinus syndrome, like sinus brady, may require some correction, not while it's in the normal cardiac range or not while it's in the tachycardic range, but if we're having periods of bradycardia, we may fail to meet the cardiac output demands of the brain. Those metabolic demands not being met have to be corrected, and one of the ways we can correct them, we'll look at later, is pacing. Well, there's only a few more. Sinus block, sinus pause, and sinus arrest all almost look the same, and what differentiates them is how frequently or infrequently the pause or the block or the arrest has occurred and when it starts back. I'll do sinus block first. The SA node fires, causes atrial depolarization and the creation of a P wave. We move through the same pathway we always do, the internodal from SA to AV node, then bundle of Hess, left and right bundle branch, causes ventricular depolarization. On a sinus block, we will have P, QRS, T. And then we may have a long period where nothing occurs. The SA node was blocked from stimulating and creating the next electrical impulse to create atrial depolarization followed by ventricular depolarization. And then we will see that they block starts over with a P, QRST. And we may see a couple of P, QRSTs. And then you can see another long period where there's no electrical activity. If you look at the monitor and just glance over, you may see what looks like asystole because it is asystole. There's no electrical energy being stimulated through the normal conductive pathways. If it's a block, I will know it because the distance between this R wave and if another R wave had occurred and I drew it in, and then the next R wave, there would be equal spacing. And then this R wave. The R waves would walk out. They would fill up the dead space, the asystolic space, the space where there was no P wave, QRS, T wave, and they would start back at the same amount, the same intervals on the block. The block didn't fire, fired when it would have fired on a normal pattern. Is it rate? What is the rate? The rate is Brady, normal, or TAC. But unlike 6 sinus syndrome, it's not toggling between the three. It's either a bradycardic rate, a normal cardiac rate, or a tachycardic rate. If it's normal cardiac rate or tachycardic rate, we won't be getting involved. If it's a bradycardic rate, we may have to do something about the arrhythmia. Is it regular? Well, no, because there's these gaps. Is it regular if I drew in that R wave? Yes, it would be because they would fall back on that same interval. P waves, are they present? Yes. Are they round, upright, all alike, 1-to-1 for the QRSs? They are. Is PR interval within normal limits? QRS within normal limits. So what's weird's happening is it's irregular, and there's periods where nothing happens at all. But if I were able to punch those R waves in, if I ghosted them into that asystolic space, they would be at equal intervals. So what does pause and arrest look like? Well, they look like sinus block. Matter of fact, I'm not even going to erase these rules because they are the same. The rules are the same except on sinus pause and sinus arrest, they don't walk out. If I were to draw the QRSs in, they would not line up with an equal interval from one R wave to another. So what's the difference between pause and arrest? Pause likely only has one missed beat. Arrest may have more than one. Block likely has more than one, but could only have one. Block walks out. Pause and arrest do not. Pause versus arrest. Pause is usually a shorter spaced time before the next beat occurs. So again, they can be bradycardic, tachycardic, or normal cardiac. They are not regular because we have spaces where we don't have any activity generated from that SA node. Are the P waves present with every complex? They are, and they're round, and they're upright, and they're all alike, and the PR interval is still within normal limits, 0.12 to 0.20. The QRS is all within normal limits. And that's all the sinus rhythms. Thank you.